With this, we move on to the next session. And the topic is hypoglycemia in the real world. Who is really at risk? To speak on this particular topic, I would like to invite Dr. Partha Sarathi Monda. He is a senior and renowned endocrinologist and attached to Manipal Hospital, Salt Lake and other clinics. He has vast expertise in this field. And to chair this particular session, I would like to invite Dr. Mary T. Cruz ma'am, who is a physician and diabetologist. She was a past president of DRWA, currently the vice president of Diabetes Awareness and You, lead auditor in ISO system. Along with her, Dr. Somnath Noshkar, who is an associate professor at IPGMER and SSKM Hospital, executive member of Howrah Town Diabetes Study Society, and he has over 35 publications in different peer-reviewed journals of national and international origin. And along with them, I would also like to invite Dr. G.P. Bhattacharya, who is a cardio-diabetes physician from Howrah, founder, member, and assistant secretary of Howrah Town Diabetes Study Society. I welcome all the chairpersons and speakers, sir, on stage. I welcome Dr. P.S. Mondol to speak on this particular session.
Welcome, Dr. Mondal, and a very important topic, particularly now that we have newer insulins coming in and all the challenges that we face.
Thank you, Chairperson, for your nice introduction. Good evening, doctors. My pleasure to be with you this evening. At first, my sincere thanks to Howrah Town Diabetes Study Society for giving me this opportunity. And you can see that my topic is hypoglycemia in today's world. Often we talk much about the management of hyperglycemia. This part is often neglected, but we understand that hypoglycemia, severe hypoglycemia, is the barrier for achieving good glycemic control. Before I move on to this presentation, I want to give you the three brief histories. One, the lady with Bell's palsy. 3 days ago, she was admitted under my care with level 3 hypoglycemia. What happened to this lady? This lady had suffered from Bell's palsy. That is why she went to see neurologists. Neurologists appropriately prescribed this oral steroid, this orally, and neurologists mentioned that your blood sugar can go up and please see your physician. The lady went to see the physician and found that blood sugar is very high, fasting was 240, PP was 360, therefore increased the dose of oral anti-diabetic medicines. When this steroid was discontinued, the patient became severely confused and unconscious, and she was admitted in my hospital, the Manipal Hospital, with CBG 36. So what is the learning point? That we need to modify our dose when the steroid is discontinued or reduced. Second lady, I see this lady for many years and she often suffers from recurrent UTI. And on the last episode, what I found, the organisms are sensitive only to these antibiotics. I must say antibacterial. And I prescribed after 2 days in the early morning, at 4 o'clock in the morning, her daughter called me, Amar ma shorita bhalo lagche na. She was sweating and I asked to check the blood glucose. That was 48. Again, I must say that I prescribed co-trimoxazole, which contains sulfonylurea, which can cause hypoglycemia. Third patient, this gentleman, 52 years old, who was driving and made one accident, and he was brought to accident emergency by traffic police. At that time, he was confused with some lacerated injury in the head. And our emergency medical officer rushed to go for the CT scan, and just after this completion of CT scan, this patient had severe convulsion. And when again he was brought to this emergency, CBG was 34. So any unconscious patient, or if you see any patient with altered sensorium, checked the CBG, and subsequently found that this gentleman was on insulin for diabetes. So hypoglycemia, not only the barrier for achieving good glycemic control, it can cause severe harm to the patient or can cause harm to other persons as well. So with this histories of 3 patients, now I will be covering these areas: the hypoglycemia, what is the definition and classification, and what are the causes and risk factors, then what are the consequences of hypoglycemia, what are the strategies we should take to prevent this hypoglycemia, and what are the anti-diabetic medicines which can cause more hypoglycemia, and what are the anti-diabetic medicines which will cause less hypoglycemia, and what is the treatment of hypoglycemia, and finally I will conclude. Now hypoglycemia, if you look at this slide, then you will find that this international hypoglycemia study group defines hypoglycemia. There is a significant, clinically significant hypoglycemia, is the blood sugar level below 54. Why this is below 54? Why this is the number? At this level, patient starts to develop neuroglycopenic symptoms. They become confused. They cannot take any decision. So this is the level where the neuroglycopenic symptoms are started. And at this point, the patient should be treated promptly, otherwise that will progress to level 3 hypoglycemia. If we look at this Canadian the Diabetic Association definition, you will find the low blood glucose with autonomic and neuroglycopenic symptoms. All you know that what are the autonomic symptoms: shaking, trembling, sweating, and this tingling sensation, and also the feeling of hunger. And you also know the neuroglycopenic symptoms, the difficulty concentration and confusion, weakness, drowsiness. All these things are the neuroglycopenic symptoms with the low plasma glucose, and the reversal of symptoms with the administration of glucose. Now these are the classification. You can see the level 1 hypoglycemia. It is the below 70 milligram of percent. Why this is below 70? In normal persons, when the blood glucose goes below 70, at that point counter-regulatory mechanism comes into play. That means that at this point the adrenergic system becomes activated, and that restores the hypoglycemia. So this is important. So if you see any patient with this level 1 hypoglycemia, you need to find out the cause, why this patient developed this hypoglycemia. If you find clear-cut cause for this hypoglycemia, then you need to address that cause. If you don't find any cause, you need to modify your treatment. And next is the level 2 hypoglycemia. As I already mentioned, there is a below 54. At that point, the neuroglycopenic symptoms appear. And you need to treat that this level of hypoglycemia very rapidly, quickly. And what is the level 3 hypoglycemia? Level 3 hypoglycemia doesn't depend on the glucose level. That is in that level where, due to the physical and the cognitive impairment, patient cannot manage himself or herself. Patient requires help from other person for recovery. There is a level 3 hypoglycemia. Now, hypoglycemia, usually that I mentioned, this is the low plasma glucose concentration that exposes the individuals to potential harm. And if you ask me at what level the patient develops the symptoms, there is no clear-cut value. There are many patients who have hypoglycemic unawareness. You will find there are many patients with the blood glucose level of 50, still they don't have any hypoglycemic symptoms. And you also find the blood glucose with the blood glucose level of 130, they are actually experiencing hypoglycemic symptoms, particularly when they had been suffered from severe hyperglycemia for a long period, say for 300, 450 blood sugar levels. If they spend long time with this hyperglycemia, then they can experience hypoglycemic symptoms even at the level of 140 milligram percent. So that is important. And you need to understand that we are blessed with so many glucose lowering drugs. So only 3 classes, the sulfonylureas, glinides, and insulin cause the risk for hypoglycemia. And if you see this blood level of 70 in these subjects, then you need to be more alert and you need to modify the treatment. These are the actually the definitions of the severe hypoglycemia. I have already mentioned documented symptomatic hypoglycemia. That means that you have checked the blood sugar, blood glucose is below 70 and the patient having symptoms of hypoglycemia. That is the documented symptomatic hypoglycemia. Asymptomatic hypoglycemia, that is a dangerous thing. You have documented the blood glucose level is below 70 or below 54, but still patient doesn't have any symptoms of hypoglycemia. That is called hypoglycemic unawareness. And this is very, very important. I will be discussing slightly in detail about this hypoglycemic unawareness. Probable symptomatic hypoglycemia. Patient is experiencing symptoms of hypoglycemia. There is no facilities to check the blood glucose level, and after taking the blood glucose, taking the glucose or sugar reading, patient recovered. Then this is the probable symptomatic hypoglycemia. Pseudo-hypoglycemia I have already mentioned. That blood sugar value is above 70 but still patient having symptoms of hypoglycemia. This is called this pseudo-hypoglycemia. This is a real fact. Often we ignore what the information patient is giving. Patient বলছে যে আমার তো 140 আমার শরীর কাঁপে, আমার শরীর খারাপ লাগে, ভীষণ উইক ফিল করি, বাট না কি বাজে কথা বলছেন, 70 নিচে যায়নি, but this is the fact, what we call pseudo hypoglycemia. Now I have discussed this thing almost, this mild hypoglycemia below 70 with autonomic symptoms, and moderate there is a below 54, between 50 to 60 the neuroglycopenic symptoms start, and severe hypoglycemia that doesn't depend on this blood glucose level. Usually you can say there is a below 50. Hypoglycemia frequency, type 1 diabetic patients, they suffer from severe hypoglycemia compared to type 2 diabetic with severe insulinopenia. And you need to understand when there is no reserve of the beta cell function, then there is more risk of severe hypoglycemia. What happens when blood glucose goes low, then beta cell stops secreting insulin. But if there is no beta cell function left, then that is the problem. So type 1 diabetic patients, they are at increased risk for severe hypoglycemia. Now this is the very important slide. This taken from DCCT trial. You know, this is the landmark trial which included type 1 diabetic patients. This study looked at that what is the benefit of intensive diabetes control compared to standard control. And you can clearly see that this complication of diabetes clearly depends on the HbA1c. So if we can achieve good glycemic control, that definitely prevents diabetes-related complications, retinopathy, neuropathy, and nephropathy as well. But if you look at here that the intensive glycemic control is associated with increased risk for hypoglycemia. So this is the big dilemma. So you need to, this is the balancing act. Now, general causes, all of you know what are the general causes of hypoglycemia. This inadequate meal or delayed meal or skipped meal, and unusual exercise. আমি কোনোদিন এক্সারসাইজ করি না, আজকে হঠাৎ করে মনে হলো 1 ঘন্টা এক্সারসাইজ করি. That can cause hypoglycemia. Too much insulin or oral anti-diabetic medications, particularly if wrongly taken in a larger dose of insulin. Alcohol is the very important cause for hypoglycemia. Increased insulin sensitivity. If someone has lost some body weight or is doing regular exercise for fitness, that will improve insulin sensitivity. That can cause again hypoglycemia. Reduced insulin clearance, particularly in the chronic kidney disease. Risk factors for severe hypoglycemia, age and the duration of diabetes. As I mentioned, when the duration of the diabetes is long, there is no more beta cell function is left. And as elderly population, they are at risk for hypoglycemia. Why? They cannot recognize these hypoglycemic symptoms. They often suffer from hypoglycemia unawareness. And again, they also may have these defective counter-regulatory mechanism. I'll come to this point. And strict glycemic control. The intensive glycemic control is another cause for this severe hypoglycemia and hypoglycemic unawareness. They cannot recognize the symptoms, that is the autonomic symptoms of hypoglycemia. Sleep, during this sleep, this counter-regulatory mechanisms is impaired. There is another important. So we are often worried or concerned about this nocturnal hypoglycemia. History of severe hypoglycemia. If anyone suffers from hypoglycemia, that means the antecedent hypoglycemia is the important risk factor for further hypoglycemia. Renal failure, you will find that when anyone suffers from advanced kidney disease, they may not require any anti-diabetic medicines. Who had been on the good amount of glucose-lowering drugs with advancement of the kidney disease, they may not require. This is due to this reduced insulin clearance, and polypharmacy is also important risk factor. Here I want to tell you that there are few antimicrobial agents like levofloxacin. I have seen one patient with a frequent hypoglycemia, intractable hypoglycemia with the levofloxacin. Clarithromycin, as I have already mentioned, the Bactrim DS, the cotrimoxazole, chloroquine, fluconazole, all these can cause hypoglycemia. Now, what are the consequences? I have already mentioned this hospitalization, like that gentleman who made this road traffic accident. CV complications, I will come to this point. Weight gain by defensive snacking or eating for the fear of hypoglycemia. Funny turns that can cause falls, seizures, accident, increased risk of dementia, and coma and death. These are the important things. Now, physicians, when we see any type 2 diabetic patients, and if we prescribe secretagogue or insulin, or any type 1 diabetic patient, when we are prescribing insulin, we need to educate them about this hypoglycemia. Now, another important thing that physicians and patients express the fear of hypoglycemia, which may interfere or impede the effective diabetes management. You will find that our subset of patients who, to avoid hypoglycemia, intentionally maintain their blood glucose to the higher level. And in those subjects, it is really difficult to achieve good glycemic control. And here I want to tell you the fear of hypoglycemia also percolates in the family members, extends to the family member. And often they are very much concerned about the hypoglycemia. And these hypoglycemic episodes, the important risk factor for cardiovascular events. That causes the endothelial dysfunction due to the increased adrenergic drive that can increase the workload on the myocardium, that can precipitate ischemic event, and also that can precipitate any malignant arrhythmia. And this hypoglycemia is also the risk factor for coagulation abnormality and also risk factor for inflammation. So, this why this CVD is increased, I have already mentioned. And if you see the right hand panel, you will find a smaller study that included type 2 diabetic patients, not the large study, it's this very small study, included only 19 type 2 diabetic patients who had been on insulin and had suffered from recurrent episodes of hypoglycemia. They were put on CGM as well as they were on continuous ECG monitoring. And you can see when they suffered from hypoglycemia, they had suffered from cardiac symptoms and also ECG abnormalities like QT, prolongation of QT intervals. And here I must say that adrenergic drive can cause also hypokalemia. That can also precipitate this cardiac arrhythmia. And this hypokalemia can also cause the platelet activation, as I already mentioned that. And if you look at the several outcome trials of intensive glycemic control versus conventional glycemic control like UK PDS, your advanced accord VADT, you will find that in the intensive arm there is the severe hypoglycemia. And this hypoglycemic episode was associated with not only this impairment of physical and mental ability, but also these hypoglycemic episodes are associated with macrovascular, microvascular episodes, complications, as well as death, cardiovascular death and non-CV death. And important thing is that after recovery from these hypoglycemic episodes, the ill effect of these hypoglycemias don't disappear, and you can see here from the study that may persist for months. And we have a few findings that if anyone suffers from severe hypoglycemia in hospital, the survival after discharge is decreased or are affected by the hypoglycemia in the hospital. This is the VADT study. You can see that hypoglycemia was an important risk factor or the strong predictor for cardiovascular death. In the ACCORD and the VADT trial, this hypoglycemia was closely associated with the CV events. So hypoglycemia is a particularly concern for elderly patients. So the disease duration is very long, and especially because, as I mentioned, they cannot recognize the CV events. This is hypoglycemic symptoms, and this counter-regulatory mechanism often is defective. And to avoid this hypoglycemia, patients often consume the carbohydrate, and that can cause the weight gain. Now, this is the important thing regarding the hypoglycemia. If anyone suffers from the hypoglycemia, that causes the hypoglycemic associated autonomic dysfunction that will interfere with the counter-regulatory mechanism, and thereby there will be less release of adrenaline, and thereby there will be less symptoms related to this adrenaline secretion. Patient will not experience these symptoms of hypoglycemia, and again there is a lack of adrenaline, noradrenaline. This hypoglycemia from this the patient will not recover. The hypoglycemia prevention, patient needs to be educated, not only the patients, their family members. Dietary intervention is important, and you need to discuss about the exercise, glucose monitoring, and in each visit you need to inquire about the hypoglycemic episodes, and also need to ask about the hypoglycemic awareness, and you need to adjust the medications accordingly. And individualization of the treatment is important. Now we have many glucose lowering agents which don't cause or don't increase the risk for hypoglycemia. You know that we have the TZD, and we have the SGLT2 inhibitors, DPP4 inhibitors, GLP-1 receptor agonists, metformin. All these will not increase the risk of hypoglycemia. You look at these trials, advanced ACCORD and VADT, again, there was the increased incidence of severe hypoglycemia in the intensively treated arm. In the elderly patient, there is no need for stringent glycemic control. You can relax, particularly when there is a comorbidity.
So kindly wrap up.
Thank you. And just one slide. And treatment, you know, that oral glucose, if the patient is alert and conscious patient, and for this unconscious or the impairment of the consciousness, you need to give the IV glucose, or glucagon is the treatment of choice. And every patient who is on insulin should be prescribed glucagon. And as I mentioned, we have the other glucose lowering is this is the summary, that this hypoglycemia continues to cause considerable morbidity and mortality. Hypoglycemia is associated to the high risk of CVD. Physicians have the responsibility to educate these diabetes patients about the hypoglycemia, and we need to choose the optimal balance between attainment of the good glycemic control and the risk of hypoglycemia. Thank you.
Thank you, Dr. Mondal, for a detailed deliberation. And as we're running short of time, so only one quick question is allowed.
Partha, good afternoon. Very fantastic speech. I have one question. You have talked that sleep is to some extent maybe responsible for development of hypoglycemia. You have mentioned in your talk sleep.
Can you repeat it?
In your talk, you have told that sleep could augment hypoglycemia because of hypoglycemia unawareness.
Yes.
Okay. In your practice, have you seen patients complaining of insomnia, particularly those patients who are suffering from chronic low-grade hypoglycemia? Have you seen such patients in your practice?
What is the question?
In your practice, have you seen patients with chronic hypoglycemia are suffering from insomnia?
Oh, insomnia. I'm not very sure whether this insomnia is the cause for any hypoglycemic
No,
sleep
it
disturbance.
is a symptom associated with chronic hypoglycemia.
Sleep disturbance.
Sleep disturbance,
Could be,
insomnia
I'm not very
particularly.
sure.
I have seen such cases, so for that reason I am asking you.
Okay.
There's no documented studies showing the relation between sleep disturbance and hypoglycemia. Sometimes patients are very afraid of that hypoglycemia and they are frequently getting up because they are afraid of going into a hypo. Anyone who has suffered a hypo is really scared, not only of medications at night, insulin, never can we convince them to take it. Even the basal they want to take in the morning, actually. It's a fear.
Yes.
Actually, I think the question is very relevant. Hypoglycemia is known to give rise to sympathoadrenal discharges, increased sympathoadrenal, increased norepinephrine and all can cause palpitation, fear as a neuroglycopenic symptoms, and that can interfere with sleep. So sleep disturbance is probably a known complication of hypoglycemia. Nocturnal hypoglycemia can give rise to sleep disturbance because of the increased sympathoadrenal response.
Yes, definitely if someone experiences a hypoglycemia during sleep, that can cause this poor quality of sleep, definitely. That can cause sleep disturbance.
Okay, so thank you.
What is the question? I don't know. What I know that during the sleep, this counter-regulatory mechanism is impaired.
Okay, thank you. We have a very enriching session, so we are concluding the session now.
Thank you, sir. I would request the chairpersons to felicitate Dr. Partha Sarathi Monda
Thank you.
for such an enriching talk. Thank you, speaker, sir. Thank you, chairpersons.